new study by the University of Sydney and the US's Duke University has found people living with cancer suffered greater stress during a pandemic because strict rules preventing a family member, a support person, or what's termed as an informal carer from attending appointments and treatments impacted things much worse. And according to Professor Alex Broom of the Sydney Centre for Healthy Societies, we need to ensure all patients have access to a carer or support person and ensure that in the event of another pandemic, informal carers aren't left out in the cold by infection prevention measures. Join us to discuss the study is Professor Alex Broom. Welcome, Alex.
Thanks, Michael. It's a pleasure to be here to talk about this.
Great, important study. And as we were talking before we came on, I've got personal experience of this and I can speak firsthand. Now, let's begin by discussing why the study was undertaken.
Well, we, after doing research for many years on the lived experience of cancer, going into 2020, were very, very concerned about what would happen in that space. The attention of virtually everyone was on COVID, was on infection control, on essentially fairly quickly distancing, and knowing the very difficult experience often of living with cancer and getting treated, and all of the day-to-day kind of complexities that having cancer and getting treated produces for people, we thought, gee, it's going to get difficult. And so what we decided to do was to interview both patients, people living with cancer, and their families, sometimes their friends, and those who are giving care to them, and to actually systematically document what occurred in that very difficult period of years for all of us, really, but in particular for people who are already often immune compromised, often dealing with very difficult symptoms, often side effects of treatment. And not only, all of the different sort of challenges of cancer, but the systems of care became increasingly disrupted. So, for example, clinical trials stopped. Even pre-cancer kind of screening started to ground to a halt. And certainly clinics were increasingly, and at certain points, refusing to do face-to-face consults. And as we talked about prior to this recording, very often family and friends could not attend clinics during that period. And often it was very unclear what the actual risk was. So, which makes it a very emotional kind of situation where no one's really clear what the actual risk is, but people are not allowed to be there to support their family, their partners, their children, sometimes in very life-threatening situations. And so we wanted to make sure that A, we documented this, and B, we made sure that if things were done in suboptimal ways, that we didn't do that in the future, that we learned our lessons, as it were.
Because let's be clear, with all medicine, there's a risk versus reward. And the risk of infection, if the reward, if the outcome is going to be worsened outcome for case of cancer patients, ongoing trauma, not only for loved ones, but also for those frontline workers who have to deal with not only the family, but also the patients just wanting to be in contact in such trying times, that needs to be considered as part of the risk versus reward of that infection control, doesn't it?
Absolutely. And if we look back over, the last 2 years or so, it was very, very fast moving in terms of understanding of risk. So at the beginning, we knew very little. Was this something which really threatened healthcare workers significantly? That was obviously pre vaccination, and really we only had observations from overseas. So ultimately, healthcare workers were rightly very, very conservative because they felt like they had really no idea what the impact could be on them. And so as a result, there was this kind of withdrawal from face-to-face interaction because of the sort of uncertainty within our institutions. And, you would hear routine scenarios where, doctors or a nurse would go into a room with a patient, but a doctor wouldn't go in because they didn't need to. Now, this idea of not needing to doesn't really capture the therapeutic relationship or the need to speak to your doctor if you're, getting treated for cancer and you're facing your mortality, to actually be with the people who are caring for you, both professional and family and friends, is palpably important. And in fact, I would argue important for survival. So what you're ultimately facing is a really uncertain scenario in 2020 where health professionals are genuinely fearful for their own lives, even though now looking back, in all likelihood for the majority, clearly there wasn't a major risk to their lives, but we didn't know that. And so that period of swiftly moving uncertainty, but also societies across or around the globe who are reacting in very different ways, created a scenario, even across Australia, of quite different approaches, which just enhanced uncertainty. And so what we saw is, from a patient perspective, the cost was really borne by patients and families, and particularly families who, had to sit in the car in the car park rather than, accompanying their life partner to receive, chemotherapy or whatever it might be, who, because they were doing the consultation via telephone, it was an individual phone call. The prognosis is not good. The life expectancy is this. And normally you would have a family or a couple or, a son or a daughter or whoever would be there. And you would have that kind of entering into the encounter with the oncologist or whoever it might be, the discussion, the emotional management of that event, and then the sort of post discussions between family and all of that emotional work, which sort of just didn't occur or didn't occur in the same way. And that increased grief and suffering associated with living with cancer. And that's really kind of our main concern. Is ultimately, yes, there were very, very good reasons for example, distancing and masking and the use of telemedicine. But actually, what we saw, which was didn't actually have to occur, but did occur, was the exclusion of social networks, family and friends from key moments in either diagnosis, prognosis, or treatment decision-making or follow-up care. And as we also talked about before, the difficult sort of end-of-life issues for many people, which would unfortunately had to be virtual and didn't allow necessarily the expression of loss and grief and kind of collective mourning that was necessary for celebrating and expressing our loss of the people that we care for. So it's clearly a very complex space where people were trying their best, but I think we have a responsibility to look at what didn't work and who suffered and how we could potentially prevent that in the future.
Yeah, and for anyone who's attended those doctor's appointments with a loved one or been supported by a loved one, the two different listening modalities that you hear, the different things that are picked up on, where the discussions where you don't have to replay exactly what they said verbatim to your support person or vice versa, to have a genuine, informed, supportive discussion around options. And a lot of the times, I know I've been there and it's just gone into shutdown after you've heard one part, and after that everything's just a blur, and being able to have that partner or support person there is just, it's vital, surely.
It absolutely is. You've hit the nail on the head. And very often after you have cancer or it's malignant, the patient doesn't hear anything. And it may in fact be followed up by, if you're going to get cancer, this is the one to get. We can do lots of, really, helpful things, and your life expectancy is actually quite good. But because of the sort of, difficulties of that moment, having someone in the room that can still listen, that can absorb the information and talk with you about it later, is absolutely crucial. And think also about that in context where English is not a first language, where ultimately having kids or partners who speak English more fluently or can translate, absolutely critical. So the issues get more and more complex for different communities, and particularly more vulnerable communities. So, and that leads us to this prickly issue of what we talk about as a sort of postcode lottery of the kind of care you get. Some of the people that we interviewed, don't live in major metropolitan areas. And of course, some who are in rural or remote areas are used to distance and not being particularly close to services. But at the same time, there are quite considerable inequalities in the context of cancer, and that shapes as well what people are and aren't able to do. And of course, in this pandemic, different states and territories around Australia had different scenarios for what they were insisting on and what they were saying was necessary. So, some people didn't get to do certain things in, Melbourne or Sydney that others in WA did. So, and then there are socioeconomic issues which shape all of the care, the opportunities for people who are living with cancer to get. So it's not linear how this played out. Suffering occurred in communities that are already quite vulnerable. And ultimately, and something that I'm quite, I emphasized a lot during the pandemic was culturally, we became so focused on what was impacting on the population at large that we lost attention on enduring very severe and life-limiting illnesses, which ultimately continue to have a much greater impact on our population than COVID. And so I think that is a lesson in what I would call the sort of politics of attention, that we get drawn into these kind of almost, I wouldn't say talk about COVID as transient, because that sounds like I'm dismissing it. I'm not. What I'm saying is the tendency to be drawn away from, a major killer of the Australian population, and which will continue to be. And I also have to say that we will probably see an uptick in deaths from cancer and lower levels of survivorship as a result of the last couple of years.
Yeah.
There is going to be an actual concrete uptick in mortality.
Yeah, we've spoken with people from the various cancer organisations that are saying there's 3,000 and something less scannings, which will result in roughly 800. That's just extra cases of cancer that will present later with worsened outcomes just because of the when they stop doing the screenings. And there's no way around that. It's just basic mathematics of, we do so many scans per year, and out of that we get so many cases, and out of that, and you know, the unintended consequences are sometimes some of the biggest ones. Now,
and you know what? We often don't document those.
yeah.
So it's the unseen consequences. That's a cost of how we approached the pandemic.
Yep. Now, Professor, did you think that you would find any problems with the sudden shift to telehealth?
So I thought most of the issues would be around how difficult it was to manage emotions when you're distanced from your patient. So I thought the sort of the pointy end of the discussion is obviously prognosis. So ultimately, you know, we don't expect you to live 5 years, or we do expect you to live 5 years, but you'll have to undergo, you know, this array of treatment. Now, what we, on one level, for those patients who were potentially younger or healthier or more tech savvy, the telephone consultation, and bear in mind, a lot of health professionals prefer telephone rather than teleconference or a video conference, which has a very different feel. So, you know, we're talking now on a video conference, and that has a sort of almost in the room quality to it, which can facilitate some of that comfort with, you know, okay, now I'm going to, you know, talk to you about essentially your death, or what might be your death within the next few years. And, you know, getting that call on a telephone, which is maybe 5 minutes in length, to then be left to process that is extraordinarily difficult. So I would say that on one level, you argue that this is just a necessary product of uncertainty about transmission, like we were talking about before. On another level, telemedicine and telehealth have been around for a long, long time. There are really quite innovative modes of interacting, as we all know, in this sort of new virtual world. There are many ways of interacting in ways that can be warm, sad, and much more interactive. So I think because there was sort of a lack of preparedness for it, it sort of resorted to a very limited sort of short phone calls. That was sort of a poor substitute for what is really quite often an overly kind of rushed conversation, because often, for example, oncologists in the Australian environment might have 20 or 30 patients to see in a particular clinic. So you're kind of, and when you're in person and you are able to see a person's reactions and manage their emotional response, you can kind of offset that, right? You can say, I actually need to spend 10 or 20 minutes more. And when the sort of distance tele kind of format doesn't really allow that kind of interpersonal work to be done by the health professionals.
Yeah. And I know from my experience too, a lot of the times as a support person, I have questions that I don't want to ask in front of the person I'm supporting as well. So you lose that opportunity. But we see study after study now talking about empathy in doctors, and the best doctors are the ones that have that empathy, or what used to be called bedside manner. Surely that is severely limited with the telehealth.
Well, I think it sort of further diminishes the opportunity for what we would call, you know, emotional labor in an interaction. So it's not delivering technical news, is it? It's actually recognizing despair or suffering or hope, but it's also inducing hope. So it's also about saying, you know, we can do this. You know, we're a team. This is this is good news on one level, that we've got things that we can do, and so that kind of the acts of which is not just compassion, right? It's recognition that this is serious, but also that this is a team effort and we're all in this together and we are going to get you through this. And that is critical to survivorship. Whereas if you get delivered the news of it's cancer, and there are X and Y treatments, come to the clinic in 3 weeks and we'll get you started, doesn't really capture what we really need in order to survive it or live with it or live as long as we can with it, which is enthusiasm. Perhaps enthusiasm is not the right word, but collective enthusiasm for giving it our best shot, for doing what we can, and living our best life with what is a difficult, often, condition to survive with. And I think that takes really significant emotional intelligence from clinical staff, of which technology can be utilized better to achieve. It's not impossible.
Yeah, and let's face it, there are reasons why we do double-blind studies, because one person's enthusiasm, lack of, can influence the other one. We are built for connection and attachment to other people and groups, and this was just a horrible, unthinking, unintended consequence that hopefully we'll learn from, and your study, Professor, will be forefront to that.
Well, I think you've hit the nail on the head, in the sense that hope, and a person who conjures up hope in another, has a powerful effect, and it's very difficult to study that. What a person who is hopeful, the effect they have on another to survive. But I think we all intuitively know that it's potent, and that ultimately makes the difference.
All right, we've got to leave it there. So, Professor Alex Broom, thanks so much for your study. I can't wait to dig in and read it. Where will it be published? Which journals?
Clinical Cancer Research, and it's already online and open access as well. So anyone can download it and read it. And I'm very happy to be contacted about it and talk further about it.
Fantastic. All right, Professor Alex Broom, thanks for your time.
Thanks so much.